Hello, everyone. And in the next about 55 minutes, we're going to review together about the updated grade guidance for imprecision rating using a minimally contextualized approach. And the focus of this session and our discussion would be when grade users should consider rating down more than one level for imprecision using a minimally contextualized approach. So the grade prior guidance on imprecision rating was published in 2011, and it is still the fundamental guide for imprecision rating in grade system. And according to this guideline, the guideline author and systematic review authors would use different primary criteria for imprecision rating. So in the context of guideline, authors should judge whether the confidence interval around the absolute effect crosses a decision threshold or not. And if it does, the authors would rate down for imprecision, and if it doesn't, the authors would not rate down for imprecision. While for systematic review authors, the primary criterion for imprecision rating is optimal information size, which means when the effect is large and the sample size of meta-analysis is modest, grades suggest to check if the sample size of the meta-analysis meets the optimal information size. That has been said to consider whether the total number of participants or events in the meta-analysis is more than the number of participants or events generated by a conventional sample size calculation for a single adequately powered trial. So the reason for the difference in the primary criterion for guideline and the systematic review is because considering the threshold might not be the obligation of the systematic review authors. So that's why in the prior grade guidance for imprecision rating, we use different primary criterion. And after the publication of the first grade guideline on imprecision, there are some important progress in grade which have impact on the imprecision judgment. So in 2017, grade published a concept paper that re-clarified the concept of certainty of evidence. So according to this concept paper, in either guideline or systematic reviews, when authors rate the certainty of evidence, they are assessing their confidence where the point estimate lies relative to a particular threshold of interest. That has been said in either guideline or systematic review context, we now have consistent concept of certainty of evidence. And when rating certainty of evidence, we first need to be clear about the threshold of interest. And this concept paper provides 3 degrees of contextualization, aiming to help grade users decide the threshold of interest, including a minimally, partially, or fully contextualized approach. And I'm going to be in detail about the minimally contextualized approach later. And all of these progress are relevant to the precision rating in grade system. And incorporating the latest grade process, grade methodologists have had some important additional insights in imprecision judgment. So the first is, in systematic reviews, we are much more likely to use the approach that relies on the threshold and the confidence interval. So hereafter, we will call this approach the confidence interval approach. Then the optimal information size to judge imprecision. And second is, we suggest more frequent rating down more than one level for imprecision when the confidence interval appreciably crosses the threshold of interest. And in this session, we will focus on great updates on imprecision rating using a minimally contextualized approach. So just to keep everyone on the same page, when authors of systematic reviews and guidelines use a minimally contextualized approach, they could rate their certainty in relation to the threshold of known effect, the threshold of minimally important difference, that is MID for short, or a range of trivial or no effect, which is formed by the MID for benefit and MID for harm. And the target of certainty rating would be whether there is an effect, whether there is an important effect, or whether a trivial or no effect is truly presented or not. Okay, so I'm going to have a pause here to see if there is any question or comments so far.
No, we don't have any questions at this point.
Okay, thanks. So in a following discussion, we will focus on examples in which authors could have rate their certainty using a minimally contextualized approach and see how many levels you think the authors should rate down for imprecision. So the first example is a systematic review of corticosteroids versus no corticosteroids for patients with sepsis. A meta-analysis reported that in a short term, corticosteroids yield 1.8 fewer deaths per 100 patients with a confidence interval from 4.1 fewer to 0.8 more. So using a minimally contextualized approach, had the author set a threshold of MID for benefit at a reduction of 0.5 deaths per 100 patients and rated their certainty in relation to that threshold. And because the point estimate, that is a reduction of deaths of 1.8 per 100, falls above that threshold, authors would rate their certainty that corticosteroids have an important reduction in death. And that is the target of certainty rating in this example. So we assume that authors do not have concerns in other 4 great domains in this example and also in the following examples in our session today. And so now consider the imprecision judgment. How many levels you think the authors should rate down for imprecision? So Oliver, could you please launch the first poll? Yep, thanks. Okay, so from the votes, I can see about 60% of the audience choose rating down 2 levels, and about 30% would rating down just 1 level, and the others would rating down 3 levels or not rating down for imprecision. Okay, very interesting. Okay, okay, so when the authors rate their certainty that the corticosteroids have an important benefit, and the confidence interval simultaneously in this example includes important harm, the authors are probably more comfortable with rating down 2 levels for imprecision rather than just 1 level. And the great updated guidance suggests authors to consider rating down 2 levels for imprecision in this situation. And another approach that we can use to help us judge how many levels we should rate down for imprecision is we can consider the Great Plain Language Summary. So in this example, if the authors only rate down one level for imprecision, they would conclude that corticosteroids probably have an important benefit. That is a conclusion which is inconsistent with the remaining possible important harm. That the corticosteroids may have an important reduction in death is clearly more appropriate, we think, and requires rating down 2 levels for imprecision. So for those who think we should only rating down 1 or rating down 3 levels for imprecision, you could give comments or your questions in the chat, and we can then discuss this later. So to be more generalizable, when rating the certainty that there is an important benefit and the confidence interval includes important harm, one should consider rating down 2 levels for imprecision. And this is one criteria in the updated grade guidance for imprecision rating. So Dory, I'm not sure whether there is some question or comments in the chat now, or I can move on and then come back later.
Yeah, there's one question. Should the plain language summary mention potential for harm?
Oh, okay, so the Great Plain Language Summary, so the first thing is that the plain language summary will focus on the target of certainty rating. So as we say that the target of certainty rating in this example is whether there is or whether there is not an important benefit. The plain language summary will only cover that part. But the words probably or may can reflect that how certain we are that the intervention has an important benefit. So I'm not sure whether that answers your question.
Just to expand a little bit,
the
plain language summaries are always very simple. They are simple statements that refer, as Linan just said, to what one is rating one's certainty in. So in this case, you are rating your certainty in an important benefit. And if it were high certainty, you would say there is an important benefit. Moderate, there's probably an important benefit. Low, there's possibly an important benefit. And that's all you would say. So the plain language summaries are simple sentences that bear only on the target of the certainty rating.
Thanks, Gordon.
Thanks, Gordon, for joining in. And yes, we don't have any further questions at this point, so I'm going.
Okay, thanks. So the second example is from a systematic review of transcatheter aortic valve implantation, that's TAVI, versus surgical aortic valve replacement in patients with severe aortic stenosis. The meta-analysis reported that the transseptal TAVI results in 5.7 more deaths per 100 patients, with a confidence interval from 1.6 fewer to 15.3 more deaths. And without specifying a precise threshold of MID, the authors could have considered that the point estimate, that is 5.7 more in 100, represents an important harm, and rate their certainty that the transseptal TAVI results in an important increase in death, and that is the target of certainty rating. So had the author consider the lower boundary of the confidence interval, that is 1.6 fewer in 100, indicates an important benefit. How many levels you think the authors should rate down for imprecision? So Oliver, could you please launch poll 2? Thanks. Okay, so we have about half of our audience think we should only rate down 1 level, and about 43 think should rate down for 2 levels, and the rest think should rate down 3 level or not rating down for imprecision. So in this example, as the confidence interval include an important benefit, and the author would conclude that although the point estimates suggest an important harm, the important benefit remains plausible. Thus, they probably would rate down for 2 levels for precision and conclude that the transseptal TAVI may have an important have an important increase in death. So I think for those who think we should not rate down for imprecision, and in this example, the confidence interval crosses the threshold of interest. So the authors should rate down for imprecision. And I'm not sure whether these audience who think we should rate down 3 levels for imprecision would give us a comment, like why you think in this case, authors probably should rate down for 3. And we would like to have your comments and we can have discussions. So to be more general in this case, when rating the certainty that there is an important harm and the confidence interval includes an important benefit, one should consider rating down 2 levels for imprecision. And Derry, I'm not sure whether there is any comment or should I move on?
No comments or questions, so come on.
Okay, thanks. So in example 3, consider a systematic review of the thyroid hormone versus no treatment in patients with subclinical hypothyroidism. The systematic review reported that the hormone results in 0.6 fewer cardiovascular events per 100 patients, with a confidence interval from 2.8 fewer to 3.6 more. Using a minimally contextualized approach, authors could rate certainty in relation to a range of trivial or no effect formed by the MID for benefit and the MID for harm. And had the authors set the MID for an important difference in cardiovascular events at 1.5 per 100, the point estimates would fall within the range of trivial or no effects. So the authors would thus rate their certainty that the hormone has trivial or no effect on cardiovascular events. And that is the target of certainty rating. And giving the confidence interval simultaneously includes the important benefit and important harm in this example, how many levels you think the authors should rate down for imprecision? So Oliver, could you please launch the 3rd? Okay, thanks. Okay, about 60% of us think we should rate down for 2 levels, and about 10% rate down 1, and 25% think in this case we should probably rate down for 3 levels, and 5% think not rating down for precision. Okay, so according to the updated grade guidance, when the confidence intervals simultaneously include important benefit and important harm, the authors should consider rating down 2 levels for imprecision. And in this case, the authors could conclude that the thyroid hormone may have trivial or no effect on cardiovascular events. And again, because in this case, the confidence interval crosses the threshold or the range of interest, that is the MID for benefit and the MID for harm, that the two red lines in on the slides. So the authors should rate down for imprecision. But the question is how many levels they should rate down. And the reason why the grade updated guideline think the authors should probably rating down 2 for imprecision is when the authors conclude that there is no or trivial effect, the confidence interval also shows that the true effect could be there is an important benefit or there is an important harm. So the authors could be not sure about the effect of intervention as trivial or no effect. So that's why we think maybe rating down just 1 level is not enough, but 2 levels may more probably reflect the confidence of on this body of evidence. So to be more generalizable, when rating the certainty that the true effect is trivial or no benefit or harm, and the point estimate is consistent with the trivial effect, and the confidence interval simultaneously includes important benefits and important harm, the grade guidance suggests the authors to consider rating down 2 levels for imprecision. And yep.
Linan, we have a question here. So should we consider optimal OIS, optimal information size, in examples 2 and 3?
Yeah, so it's a great question that I also prepare some slides later on. So like when we should consider the optimal information size. So the situations in which we should consider optimal information size in the updated guideline is when the confidence interval does not cross with the threshold of interest. We are then going to consider the optimal information size. So like you mentioned in example 3 and example 2, the confidence intervals crossed the threshold of interest. So we applied the confidence interval approach and do not need to consider the optimal information size because we've already rated down for imprecision using the confidence interval approach. Yeah.
Just to absolutely right. Thank you, Linan. Just to add to that, if anybody is familiar with the original Journal of Clinical Epidemiology precision guidance from the grade working group, there was a big focus in the context of systematic reviews on optimal information size. In updated guidance about about how to handle precision, we have moved the focus away from the optimal information size. And we've said, even in the context of systematic reviews, we do not invoke the optimal information size, or we restrict invoking it to one situation. And that is when there are large and implausible effects. So otherwise, we have shifted to a focus that Linan is presenting to us on thresholds and seeing the relation of the confidence intervals to our thresholds, and only invoke optimal information size when there are large and implausible effects.
Yeah, thanks, Rory. Okay, so let's move to the fourth example. So in the fourth example, let's return back to the systematic review of corticosteroids versus no corticosteroids in patients with sepsis. And this time, the outcome of interest is a stroke. The meta-analysis reported that corticosteroids yield 0.5 more strokes in 100 patients with a confidence interval from 0.3 fewer to 4.5 more. And had the authors set an MID for benefit and an MID for harm at a difference of 1 stroke per 100 patients, the point estimate would fall within a range of trivial or no effect. And the authors would rate their certainty that the corticosteroids have a trivial or no effect on stroke, and that is the target of certainty rating. So because the confidence interval crosses the boundary of an important effect, the authors would certainly rate down at least 1 level for imprecision. And the question then is whether the boundary of the confidence interval, that is the 4.3% increase in stroke, is large enough to warrant rating down more than 1 level. Okay. So Oliver, could you please launch the fourth poll? Yeah, thanks. So in this case, how many level or levels do you think the authors should rate down for imprecision? Okay, so we have about 46 rating down for 1 and 46 rating down for 2 and 6% rating down for 3 levels and still 2% not rating down for imprecision. And so according to the updated grade guidance, in this case, the more important the outcome, the greater the likelihood of rating down 2 or more than 1 level for imprecision. And it is also important to notice that using the confidence interval approach, the authors do not need to set an explicit threshold of moderate or large effect, but instead judge whether the confidence interval extreme is likely to represent a moderate or a large effect. So our judgment would be that as stroke is sufficiently important and the 4.3% probably present a sufficiently large effect, we would rate down 2 levels for imprecision. And again, another approach could be to consider the plain language statement that would accompany decision regarding whether to rate down 1 or 2 levels for imprecision. So would one be comfortable with the statement that it is likely that corticosteroids have trivial or no effect on stroke when it remains possible that corticosteroids results in 4.3% increase in stroke? And if not, the more comfortable statement would be that they may result in little or no effect on stroke. So in that case, the authors would rate down 2 for imprecision. So example 4 shows that when rating the certainty that the true effect is a trivial or no effect, and the confidence interval includes substantial important time, one should consider rating down 2 levels for imprecision. And the next example is from a systematic review that compared the azacitidine monotherapy, that is AZAM, versus azacitidine combination, that is AZAC, in patients with the acute myeloid leukemia. The meta-analysis showed that the monotherapy yields 4.6 fewer thrombocytopenia in 100 patients with a confidence interval from 11.2 fewer to 3.1 more. And had the authors set the MID for benefit and the MID for harm at a difference of 5 thrombocytopenia events per 100. The point estimate would fall within the range of trivial or no effect. They also could rate their certainty that the monotherapy in comparison to the combination has a trivial or no effect on thrombocytopenia. Because the confidence interval crosses the MID for benefit, the authors would certainly rate them for at least one level for imprecision. So the question is, how many level do you think the authors would rate down for imprecision in this example? So we have 50% think should rating down 2 levels and 45 think should rating down 1 level. Okay, so in this case, yeah. Sorry.
So a couple of things. We have a number of examples where it's split about 50-50 between 1 and 2, and there was one where it was close to 50-50 between 2 and 3. This demonstrates that there is no right answer, that these are judgment calls. So the new guidance suggests guidance that people should consider and look at, and situations in which you might consider rating down to. But people who either the 1 or the 2, neither should consider themselves right or wrong, because some of these are close calls. And that goes to reflect an important aspect of grade. Grade guidance does not expect everybody to agree, but what it gives is a common way of looking at the problems. And so we're talking the same language when we make our decisions. That's one point. No right answer, and one could argue both points of view. The second is that we find the plain language summary very helpful. So thinking about whether one is more comfortable with a probably has a particular effect or may have a particular effect can be, we found, very helpful in deciding which way to go in these close calls.
Yeah, thanks, Gordon. So as Gordon mentioned, they're always involve value judgment. Like in this example, if people think that the 11.2% decrease should really represent a large effect, people may probably more inclined to rating down 2, while for those who do not think that the 11.2% represent a large effect, would probably more inclined to rate down just 1 level for imprecision. Yeah.
Linan, we have a brief question. Is there a threshold for large or very large effect size?
So in terms of the absolute effect, how we set the threshold depends on the importance of the outcome. So there is not an exact threshold for large or very large effect that can be used across all outcomes. So it depends on the importance of the outcome. The more important of the outcome, the smaller magnitude of effect will require for setting the large effect threshold for that outcome.
And if you're looking for, so Linan's absolutely correct that it differs in the context. But in any context, if you're saying, does grade tell you what a large effect is? The answer is no. A very challenging problem, which Holger Schineman's leading a effort to address that, but it is very challenging. And at the moment, it is inevitable. I think inevitably it's going to remain subjective. So nobody can tell you absolutely what a large effect is, just like nobody can tell you absolutely what a minimally important difference is. So the point is that what authors should do is be explicit about what threshold that they have chosen, and people can then agree or disagree whether it's an appropriate threshold.
Yeah, thanks, Gordon. And as we mentioned in an example earlier, that for these judgments, like whether the extreme of the confidence interval represent an important or an large effect, the authors do not need always have an exact threshold of what is a large effect threshold is. But we can make judgments that whether the boundary or the extreme of the confidence interval represent a large or an important effect. So, and do we have any other question or comment?
No.
Okay. Okay, so another principle here, and also like Gordon mentioned, it's the suggestion from grade, like how we can consider the imprecision judgment is when rating the certainty that the true effect is trivial or no benefit or harm, the point estimate is consistent with a trivial effect. The confidence interval includes substantial important benefit. One should probably consider rating down 2 levels for imprecision. Okay, so the next example is from a systematic review that compare a reduction dose regimen of glucocorticoids versus a standard dose regimen in patients with vasculitis. The systematic review reported that the reduced dose regimen yield 2.1 fewer deaths per 100 patients, with a confidence interval from 6 fewer to 3.6 more. And had the authors rated their certainty in relation to the known effect, they would rate their certainty that the reduced dose regimen reduces mortality, and that is the target of certainty rating. So had the authors considered the upper boundary of the confidence interval, that is 3.6 more in 100, indicated an important harm, how many levels do you think the authors should write down for imprecision? Okay, so in this example, we have 75 of our audience saying should rate down for 2 levels, and the others say should rate down 1 or 3 levels. Okay, so we think that giving the authors consider the upper boundary that the confidence interval indicated an important harm, the authors would probably conclude that although the point estimate suggests a benefit, important harm remains plausible, and the authors would be likely more comfortable with rating down 2 levels for imprecision. And the plain language summary could be the reduced dose regimen may have a benefit in reducing mortality. So when rating the certainty of non-zero benefit and the point estimate suggests benefit, the confidence interval includes important harm. Grade suggests to consider rating down 2 levels for imprecision. So do we have any question or comment?
No, we can move on.
Okay. So the next example is from a systematic review of a low intensity pulsed ultrasound lepers versus no ultrasound in patients with fracture. The systematic review reported that lepers resulted in 5 additional days before patients could return to work, with a confidence interval from 15 fewer to 20 more days. And rating certainty in relation to the null effect, that is the mean difference equal to 0, the authors would rate their certainty that leper increases the days off required before returning to work. So without specifying a precise threshold of MID for benefit, how many level do you think the authors should consider rating down for imprecision in this example? So we have about like 70% think the authors should rating down 2 levels, 13% 1 level, and nearly 20% 3 levels, and 2% not rating down for imprecision. Okay, so without specifying the precise threshold of MID for benefit, the authors could have considered that the boundary of the confidence interval most favorable to leper, that is 15 days earlier, indicates an important benefit. And then would rate down 2 levels for imprecision.
So this relates to a previous comment about what is a large benefit and the subjectivity. If one believed that 15 days getting better, having your fracture, getting back to work 15 days earlier was a large benefit, and getting back to work 20 days later was a large harm, one might rate down, one might well rate down 3 levels. So large benefit to large harm, but if you consider 15 days and 20 days moderate and not large, maybe it's rating down 2. So again, it comes back to a value judgment, and no one can tell you which value judgment is right. Again, the point, the necessity to be explicit about what your thresholds are when you're doing a systematic review or a guideline.
Yeah. Okay. Yeah, thanks, Gordon. So yeah, this example again illustrates that the imprecision rating always involves the value judgment. Yeah, and as you mentioned that if the point estimates suggest a harm and the confidence interval include important benefits, we would probably rating down 2 levels. But if the confidence interval simultaneously include large benefit and large harm, we probably would rating down 3 levels for imprecision. So here is the summary from the updated grade guidance about when one should rating down 2 levels for imprecision based on the confidence interval approach. And the 7 examples we've discussed probably give some indicates about how the authors could making such judgment. And so next we will move on to another part of this great updated guidance about when and how we should consider the optimal information size. But before that, I'm just going to check whether there is any question or comment.
Okay, so first to clarify that the link I've shared previously was to an earlier guidance for precision, and then Matteo shared the new one. So make sure that you're referring or you're referring to the latest one. Now the questions, probably one's value regarding what is a large benefit or harm would depend on the baseline risk of the patient without treatment.
Yeah, I think so, because I think the baseline risk will also have impact on people's judgment of what is an important or what is a large effect. Yeah, that's my understanding. I agree. I'm not sure whether, Gordon, you have anything to
Well,
comment.
you're getting to a so consider the following. We always have to judge the size of the effects on the basis of absolutes and not relative risk. So consider, for instance, why do we say that? Well, a 50% relative risk reduction can be from 2% to 1% or from 40% to 20%. So that same 50% relative risk reduction can be a relatively trivial absolute effect or a large absolute effect. So when we're judging importance, we always have to consider absolute effects. And if you were a health economist and using expected utility theory, a 1% absolute difference would mean the same thing. It's the same absolute difference, whatever your baseline risk. However, human beings do not operate by expected utility theory. And most of us would think a reduction in risk from 2% to 1% is much more important than a reduction from 50% to 49%, even though it's the same absolute 1% reduction. So the suggestion is correct that the same absolute reduction, which for a health economist would mean the same benefit or harm, human beings are different. We value that 1% reduction differently depending on what the baseline risk is.
Thanks. And there's another question. I'm not sure if that's related or not, but most of the examples are based on risk difference. Do you recommend basing judgments on risk difference rather than risk ratio?
Always, always. And it's for the reason that I tried to illustrate there. A 50% relative risk reduction looks like a large relative risk reduction. However, it can be at the extreme a reduction from 2 in 1,000 to 1 in 1,000, totally trivial, or it can be very large. So when in therapeutic situations, we're trading off benefits and harms, we always have to be trading off absolutes and not relatives. With the proviso that I just said, that depending on the baseline risk, we may value that absolute risk reduction somewhat differently depending on the baseline risk.
Yeah, thanks, Gordon. So as Gordon and I discussed before, or when we were preparing for this session, we think that the confidence interval approach should be the main approach that for imprecision rating. So we think that we covered the most important part of our lecture already. And so for the next part is about the optimal information size. We have about 8 minutes left. I will try to cover, but if there is any question or comments, I'm happy to take these questions or comments after the session through by email. Okay, so based on the confidence interval approach, when the confidence interval overlaps with the threshold of interest, authors should rate down for imprecision, and if not, authors would not rate down for imprecision based on the confidence interval approach. But as great prior guidance on imprecision noticed, when the effect is sufficiently large, that the authors consider the results implausible. So for example, a relative risk reduction over 30%, the confidence interval might be fragile, and the grade suggests to implement the optimal information size approach. That is, whether the sample size of the meta-analysis is larger or smaller than the optimal information size. And in the grade updated guideline, we focused on when, based on the optimal information size approach, the authors should consider rating down 2 levels for imprecision. And it is also important to notice, and also related to one of the questions, that all assessment and steps in the optimal information size approach focused on the relative estimates of effects, while when we are using the confidence interval approach, all of these process or steps should be done based on the absolute effects. So for dichotomous outcome, when the ratio of the upper to the lower boundary of the confidence interval is more than 2.5 for odds ratio or 3 for the risk ratio, one should consider rating down 2 levels for imprecision. And the threshold of 2.5 or 3 is based on simulation conducted to inform grade guidance for addressing imprecision in the context of network meta-analysis. And this simulation suggests that when the ratio of the upper to the lower limit of the confidence interval is higher than 3.5 or 3 for relative risk, the sample size of the meta-analysis is for any reasonable combination of the baseline risk and treatment effect very far from meeting the optimal information size. So the authors do not need to calculate the optimal information size, but can rate down 2 levels for imprecision. And if on the other side, the ratio is less than this threshold, the authors had to calculate the optimal information size and compare it to the sample size available in the meta-analysis. And then it is likely that the sample size of the meta-analysis is not far from the optimal information size. That means the author probably would not rate down, or probably rate down just 1 level for imprecision. Probably we can go through this example. So this is from a systematic review of topical antibiotics versus no treatment for chronic sympyretic otitis media that include only 1 RCT with 40 patients. So compared with the control group, the antibiotics led to estimates of 35 more patients who achieved the resolution of year discharge per 100 patients, with the confidence interval from 6 more to 64 more. And so had the author set the MID for benefit at an absolute increase in patients with symptom resolution of 5%, they would not rate down for imprecision using the confidence interval approach. However, as the relative effect of 88% increase represent a large and possibly implausible effect, the sample size of 40 is small, the author would want to determine if the optimal information size is met. And as the ratio of the upper confidence interval boundary to the lower confidence interval boundary in terms of relative risk is 3.2, which is higher than 3. So without calculating the optimal information size, the authors could rate down 2 levels for imprecision, because in this case, the sample size is far less than the optimal information size. So in the updated grade guidance, we also have other examples for rating down 2 levels for imprecision based on optimal information size calculation. but we do not have time today to go over through. But you can refer to this paper, and I'm happy to take any question or comments after this session regarding any questions about this guideline paper.